Hello, welcome. My name is Victoria, and this is my review of cholecystitis. Welcome to this study session. Consider subscribing. So, cholecystitis is an inflammation of the gallbladder, where the gallbladder becomes inflamed. And in these conditions, we have different causes or different types, rather, of cholecystitis. So I'll start with the types, and we have acute cholecystitis, chronic cholecystitis, and acalculous cholecystitis. For the acute cholecystitis, let's remember that this occurs due to a gallstone that obstructs the cystic duct of the gallbladder. So when that gallstone goes to the cystic duct, it kind of prevents or obstructs the outflow of the bile salt. So what happens now is that the presence of the stone triggers an inflammatory response. There will be inflammation. There will also be backing up of bile inside the gallbladder. That stasis of bile going on there will continue to cause pressure build up within the bile, and then there will be poor outflow of bile salts. So what happens is that this patient begins to experience pain, begins to have formation of more stones, and then there's inflammation of the gallbladder. We also have the causes of this whole thing. It can be caused by obesity, high calorie diets, when you eat foods high in calorie, and then even the cholesterol lowering medications can cause this. People who are fasting, and those who even take low calorie foods, that's calorie poor diets, what happens is that this also has a way of increasing the cholesterol in the bile. So when the cholesterol is increased in the bile, it results in the sluggish outflow of bile salts through the cystic duct, and then it will build up, causing more inflammatory response within the bile. So the increase in cholesterol leads to slowing of the outflow of bile salts. There is also stasis, like I said, and then formation of stones. Now these stones will now start to move. They will migrate to the bile duct, and then they'll cause ductal inflammation. So that inflammation of the duct is what we call cholangitis. And then when the stone continues to form, we have what we call cholelithiasis. The stone can block different places. It can go and block the cystic duct, the common bile duct. Remember, the common bile duct, if you trace it upwards, it leads to the liver. That's the hepatic duct. And then that one can also start giving us this. The patient starts presenting with signs of jaundice when it affects the liver. Now, the bile itself is a chemical irritant. So in the chronic cholecystitis, the issue is not due to gallstones. Chronic cholecystitis happens when there is something that is causing ineffective emptying of the bile salt. Yes, you want to use my crayon? Oh yeah, use it, baby. So, if there is ineffective emptying of the bile salts from the gallbladder, that will also lead to accumulation of the bile salts within the gallbladder, which can also cause this chronic cholecystitis. Another cause is that this chronic happens slowly over time. It's not an acute thing. It continues to build up, and sometimes people can have these acute attacks of cholecystitis, it will go, it comes, it goes like that and like that. Another cause of chronic cholecystitis is when there is a problem with the musculature of the gallbladder itself. So that's issues with the musculature, probably the chemical irritants, the bile salts have been there beginning to cause ischemia. Then you know, the bile is a chemical irritant. It irritates the musculature of the gallbladder. Then those chemical irritants lead to ischemia as well as necrosis of the gallbladder. And then you see the gallbladder becomes fibrous. And when it's fibrous, it will not be pliable. It cannot contract effectively to give this good squeeze to eject the the bile salts rather out of the gallbladder. So this is what happens in the chronic cholecystitis. Then in the acalculous cholecystitis, this one is happening not as a result of a calculi, not due to a stone, but it may be due to trauma happening somewhere in the body or patient taking total parenteral nutrition. It can also be due to bacteria infection, so which will now travel through the vascular system and through the lymphatic system and get to cause havoc in the gallbladder. So these are the causes of this whole thing. The assessment finding include, we have nausea and vomiting, indigestion, the patient is going to be belching, the patient will have epigastric pain, as well as a characteristic right upper quadrant pain, which is referred to the right shoulder. Okay, it's referred to the right shoulder. And sometimes you see that when you just take a high fatty meal, such as, let me give the example I always give. I say you just ate fried eggs, you did fried yam, and then you did fried plantain. You finish eating your high fatty meal, and then the patient starts having this pain 1 to 3 hours after eating this meal. And then you say what the patient complains of anorexia, nausea, vomiting, there's flatulence and epigastric pain. So sometimes these symptoms may just be there when it's just starting, like the disease process just begun. You may just have this mild signs and symptoms. You feel this pain, abdominal pain, epigastric pain. You don't really know what it is. So this is what the patient is going to be complaining of. But when that gallstone remains there, or they become necrosis of the tissues there, it can lead to perforation. Perforation of the gallbladder. Okay, and when the gallbladder perforates, what happens? We have what we call peritonitis, because it will release its content into the abdominal space, the peritoneum. So we have this garden. You see the person guarding the abdomen. There will be guarding, abdominal rigidity, rebound tenderness, and then we have the Murphy sign, which is characteristics. This one occurs when you palpate the right upper quadrant and the person cannot breathe in deeply due to pain, so much pain. So you elicit that sign and you know that we're dealing with that. We also have increase in temperature, tachycardia because of the ongoing disease process, signs of dehydration. So what do we do? What do we do for our clients in this situation? We manage them. We manage what we are seeing. We manage we give them IV fluids, we monitor their electrolytes level. We can do abdominal gastric suctioning. We suction the low suction though through the NG tube if the patient is vomiting severely. If the patient is vomiting severely, we just put the low suction via the NG tube. Keep them in a semi-fowler position to promote comfort. Then give them pain medication such as morphine, the opioids. You can give them opioids, you can give them NSAIDs, okay? Give them antiemetics because of the nausea and vomiting, and then antipyretic because they are having fever. So usually this whole thing has to be treated first. After treatment, before we can now say patients can go back for elective cholecystectomy. They also have this biliary colic, the cramping pain. That is also associated with the stone. As the stone moves through the biliary tree, then they can also have this. Then for the lab values, we are going to be seeing leukocytosis, increasing the WBC, white blood cell counts, increase in serum bilirubin. That is when we have hepatic involvement. Then the liver function test too will be abnormal. All right. There will also be increased alanine transaminase, that's the ALT, and increased aspartase transaminase, that's AST. These are what we see in this patient. So how do they manage them? They can do this. Good boy, you know your ABCs? Okay, I'm coming, okay? So we have lithotripsy, that is the extracorporeal shock wave lithotripsy. This one uses a shock wave delivered to the area where we have the gallstones, and then it dissolves the stone into bits and pieces like fragments, and then the patient will pass it out when the gallbladder contracts. So as they are trying to pass it out, that is where they have this biliary colic, this abdominal cramping as the stone moves out to be excreted. There is also the endoscopic retrograde cholangiopancreatography, where a fiber optic endoscope is used to visualize the biliary tree and look at it very well. Then as he's looking at it, you can see. Okay, wow, wait, good boy. You can see the biliary stones. Then you remove the stones, drain the bile sludge out of the bile, and then take sample like snippets of tissue for biopsy can be collected using this procedure. We also have laparoscopic cholecystectomy, which is less invasive. So the abdomen is sufflated with CO2, and then they introduce a laparoscope through a small incision made in the abdominal area, and then the gallbladder will be deflated and then removed through that abdominal incision. I also have cholecystectomy, where we remove the gallbladder through the right upper quadrant incision. Then sometimes after this is done, a T-tube can be placed, and we need to know our nursing responsibilities for this T-tube. So when this T-tube is put in place, it's placed around the common bile duct area to help with the passage of the bile until the edema within the gallbladder has reduced. So the bile products are being collected out into a gravity drainage pouch, that kind of thing. And then what do? We also make sure that this thing is draining efficiently, and we want to see about 200 mils. That is it. 200 mils of bile, less than 200 mils of bile should be drained every day, at least for the first 2 to 3 days. If we get an excess drainage of 500 mils, we report the HCP. All right. Keep the patient in the Fowler position so that gravity can help to push out the bile into the drainage pouch, or into the drainage bag. Yes, that is what we want to do. So when this drain has finished collecting what it needs to collect, then it will be removed. Then we need to assess this patient, check if the stool color is normal, and then as the drainage is coming out, you look out for the color. What is the color? What is the amount? The odor. We know the basics which we need to do. Check the odor, check the amount, check the color and consistency of the drainage. Check the surrounding skin the skin around the site of insertion, check it for inflammation due to bile leakage, because we know that bile is a chemical irritant that can lead to skin breakdown. Then we maintain this patient on MPO as prescribed, and then we advance the diet as tolerated. Then we do wound care and teach them to look out for signs of infection, such as the purulence, drainage, inflammation, redness, and swelling along the site. Then we know that there is a problem. Give them the antibiotics, prevent infection, assessment. We should be doing abdominal assessment to look out for peritonitis every 4 hours. Every 4 hours, we're assessing to see if there's signs of peritonitis. And then we monitor their temperature, because we know that once we see elevated temperature that is up to above 100 degrees Fahrenheit or greater than 38 degrees Celsius, we are thinking about infection. Now, the most important thing is that we need to manage the pain well. When we manage the pain well, post-operatively, they can now start doing their exercises, ambulating, doing their deep coughing, incentive spirometry, so that there's no problem going to the lungs. So we need to promote pulmonary hygiene, because this incision is near the diaphragm, and we know how important the diaphragm is, as is the major organ, is the major muscle for our respiration. So don't irrigate or aspirate this the drainage bag. Don't irrigate it. Don't try to aspirate the content. Say, let me withdraw the bile, except that was prescribed, okay? And then don't clamp the tube. Don't clamp the tube, because you obstruct the outflow of bile, and that will be a problem. You can only clamp it when they are eating, if that is prescribed, okay? And remember to keep the T-tube drainage bag below the level of the gall bladder, so that gravity can pull out the bile, the content within it, can pull it down. So, like I was saying earlier, if it is prescribed, you can only clamp the tube before a meal. But as you clamp it, you need to watch out for abdominal discomfort, abdominal distension, nausea and vomiting, chills and fever. If any of these things occurs, unclamp the tubes and monitor this patient. So this is my impression. This is my review of cholecystitis. If you enjoyed it, kindly subscribe to the channel, leave me a comment below, and let's add to our knowledge. It's a study session. Let's add to our knowledge. Let's see what we need to add, and what else can be done for these patients. We need to monitor their nutritional status. We monitor their nutritional status to see, because because they have this pain after eating they had high fatty meals. You see them not wanting to eat, so they may become they may start having low weight. So for their diet, we want to give them good food. We want to limit the fat, though, when they are acutely ill. All right, thank you very much for listening.